So in the end of the day, we have to really start thinking about what are we looking at and dig into these tools and determine what is it that we're doing. And from the basic standpoint, you identify the problem. You use the basic aspects of treatment to then focus on and treat that problem with the evidence, and then you create the payment models around it so that you can sustain it and then expand it to meet the need that you find when you identify it. So every time I start talking about this stuff and get on the proverbial soapbox, which I don't actually have one here, which I talked about earlier, I could use one, but there's always pushback, and this is the point where I want to talk about the pushback, and the only way I can talk about pushback is to hear it. So you can say it, well, I've heard people that think this. You don't have to say, you know what I think. You don't have to go out on that limb, but you can say, well, when I hear what you just said, I hear other people saying this about any of those things that we talked about stimulants, about marijuana, about tobacco, about all of that, because my goal with having people come at me for reasons they couldn't institute screening in primary care was to let you know that there are really answers to every single one of those questions. And so let's walk through some of the reasons that these other things are not true. Anybody? Yeah.
You've mentioned that people refuse heart stents sometimes.
Yeah.
What if somebody refuses services for substance use?
Yeah, good question. Free will. I mean, that's what the question's about. It's a philosophical question. And the philosophical question about free will is that people have it. People can choose not to get treatment. This is not, this is America. I'm from Texas, so America. This is America. So in this country, you can choose to make a bad decision. You can do that. And you know what? My job as a physician is not to argue with you about that. My job is to give you the data, the science, and the math, and be there for you when you need it and want it. And if you don't, I'm sorry for you, and I will help counsel your family. But at the same time, I don't have to save everybody. The day I learned that, I was super sad and super happy. Like, I was sad because I realized that you can't save the world. But then I was super happy because that was like a whole lot of like, God, I gotta save the world. This is like, every day was like a slog, right? And so now when you're like, look, I don't have a dog in this fight. I care about you. I want you to get better. I want you to do this. These are the ways we can do it. These are the things. And you would feel better if we did this. So I don't have to preach to you. This is what it is. And if you don't want to get better, fine. Fine. You have the right to live your life. Unless it criminally impedes on somebody else's. And then at that point, you don't have the right to live it in the way that you've chosen. Because we have rules in our society that require us to keep me safe and my family safe. And so if you're going to continue to drink, then you should not be able to drive. If you're going to continue to smoke weed, then you should not be in a safety-sensitive position. Because you are not going to work at the capacity that you could otherwise. And that's just science and data and not opinion. So as we start to look at these, if you don't want treatment for your opioid use disorder and you don't want a medication-assisted treatment and you want to go to abstinence-based treatment and all you want to do is the 12-step, great, that's fine. I'll set you up. I know all the ones around. We'll get you in. We'll set you up. We'll set you up with one that probably is going to be better fit for you. That's fine. If you want these other things, they're here. Here are the outcomes. The outcomes are better in this situation, but if this is the way you want to go, maybe it is the right one for them because they're really motivated to do that. Because people know themselves better than we do. But the free will aspect is important to understand. And if people don't want to get better, there are still consequences for actions. It doesn't take those away. And that's the part that we can just have to live with as society is we've offered you treatment. We've offered you these pathways. If the consequences are that you inadvertently break a law, then you break a law. And that has consequences. And it has consequences for safety reasons. It doesn't have consequences just because we don't like it. I mean, murder is against the rules for a reason. Vehicular homicide is against the rules for a reason, and there is punishment for that for a reason, because that devastates communities. I mean, I've seen communities this size have a truck full of like teenagers killed because of drinking, and that place is freaking wrecked for like years, the whole community. So this is not about the free will aspect of do they want treatment? Because of course we're not going to mandate that. We're going to give them their options and we're going to do it. The slippery slope gets to be when I was in the emergency department, there was always a part of me that said, man, I'm just going to walk up and give that guy a shot of Vivitrol while he's totally snockered in the bed. That's what I wanted to do. That's completely unethical, and we learned that through, Tuskegee and a whole lot of other pathways that we know are significantly unethical. But it doesn't mean that those thoughts don't go through your brain. Just like, I wonder if I push this guy in front of the train. Do you guys not have that one? No. But when we start to look at all of these aspects, we have to look at it from a human piece too. If it's my kid, I'm going to be like, I'm taping you in a box and I'm sending you to another country and you're going to have shots of like Vivitrol, Ambup, and everything. There's like going to be like a whole thing. But there's no free will for my kids. That's different.
If we argue for maintenance and your patient is not compliant with the urine screens or you're not following up on counseling, what do you suggest in that situation?
So a patient who we know, so here are the two ways to separate that first. So there's one separation cohort. One is I have somebody on maintenance with either bup or methadone, and an agonist therapy, and I have them on that, and they're completely stable in their opioid use disorder, meaning they're not using heroin anymore, they're not using these. That's a person who that medication is doing what it's supposed to for the one drug that it's FDA approved to treat. It doesn't mean that that's going to immediately turn off the behaviors with the other ones. However, there's a risk benefit. So if they're still using a lot of these other medications and they're coming in positive for benzodiazepines and things like that, again, there's a pathway called negative contingency management that may not really exist in the literature, but we use that all the time for rehab, and we use medication dose around that. So we will say that every time that you come in and you're positive, we will decrease your dose. Every time that you come in as you were negative, we will actually get you something positive like a taxi voucher or a gas card or something like that on the positive contingency management side. So it's better if it goes both ways, but it doesn't have to. And these are patients that you work. There will be a minimum dose. It's easier for methadone because they don't have that to divert. When they leave, they have to take it there, and you can remove take-home doses. You can do those things. But if they're getting a daily dose, it's harder for buprenorphine because they're taking it outside of the walls, and so we will decrease those doses. Now, if you have other drugs being used and they don't have a job, the question that I always come up with is, how are you affording those? And it usually has to do with diversion if you're writing for buprenorphine. And so those patients either clean it up really quick within a month, or we move them over to an OTP, where we can have a higher level of monitoring and it's not a prescription. Because I know they're selling the buprenorphine to get the other drugs, and that's not okay. Or if they're failing agonist therapy and you have a person who's, and for those patients, if they refuse and they're not getting well, then you just have to wean them off. And you say, we'll continue to see you and treat you, but we're just not going to give you another controlled substance on top of these. And I always offer them naltrexone or Vivitrol as their that throughput pathway. So if they refuse medications, then they refuse medications. But you should never fire them, and that's what I always talk to OTPs about and puke clinics is don't ever fire your patients, because sometimes they're going to get that moment of motivation, and if they can walk in at that moment and have somebody that's positive, and so our patients who have melted down and failed out of our initial pathway, and we failed them in a lot of ways as well at the beginning, and when they show up, if they show up, we're like, oh my God, it's so good to see you. Let's get you in and we'll make sure and get you seen. And you know what? You miss lunch, you stay late, you do what it is to get those patients, because at that moment, they want to get better. And you need to be able to do that. So you have to be able to meet them where they are in a sense, but you can't let them use that situation so that they can get high, because if you have somebody on methadone or bup, they'll boost with other medications, and you're not really treating the addiction. And that's the conversation I have is, look, I'm not treating addiction here. I'm harm reducing for all those reasons that we talked about, where it's decreasing your risk of HIV, hepatitis C, and that, but I'm not treating addiction, and I'm not okay with that. And so having that conversation with them and pushing through, and if they can't, then you have to just wean them down and offer them the behavioral therapies and the non-controlled substance pathway of treatment. And they may choose not. They may use their free will to say, I don't want the injection because I'm not ready to get off of this drug. That's fine. But it comes also down to you can't save the world, and all the work that you're going to put in on that patient, you could have had 5 other patients that you could have actually moved through that are very motivated in care, because we have a limited availability of a product, and so we should be definitely aiming at those with the highest potential of getting better, which again, as a physician, like crushes me to say, because that's just like the opposite of how you come into this business, but it's reality. Yeah.
Patient satisfaction and reverse bias. Middle-class white girl coming in to talk to me with, the way she looks and the way I look, and she's going to come in and tell me about my drug problem. I think sometimes it has to do with the finesse and the way you deliver the message, but then also there's a manipulation factor there. So, how do you navigate around that?
Yeah, so this is my favorite question. Somebody else has to open this can, because I never do. So race in medicine, that's just call it what it is. So that's a big part of what that is. You don't know who I am. You don't walk in my shoes. You don't live in my neighborhood. You don't do what I do. And my answer to them is always, duh. That should be really obvious that you and I are from completely different backgrounds. But then I push back and I go, for you to say that color somehow is culture is really not smart. Because I have plenty of friends of mine that look a lot like you but don't act anything like you. So color is not culture, first. Second, without question, because of your color, you have received worse care than other people. And here's the data to show it. I give them the publications because we have a mountain of them. I go, here's the data to show that medicine is racist. Duh. This is not news. If it's news to you, then, oh man, come out of the hole. It is. Period. There's no question about it. It is delivered in such a way that it absolutely and deliberately, whether it's unconscious bias or conscious, is delivered in such a way that it delivers less of a product specifically to African American females, followed by African American males, followed by Hispanic females, followed by Hispanic males, and then anybody else who happens to have a tan color other than mine. This is serious. If you feel uncomfortable about this conversation, we just kind of let's get over that. Because this is a reality. And if you don't, really come at this and understand this as best you can, because I'm never going to understand it. I'm never going to do it. And I get this when I go into Camden and we walk around the neighborhoods and we go into houses. I don't look or act I'm not from Camden. And they know that. But as long as you just own that and this is what it is and don't plan on trying to tell them who to be or what to be, then they don't really care. They really don't. But you have to own up to the fact that their thought process in the back of their brain where they think that they're not getting the same thing as somebody who looks different from them, that's true. That's true, and you have to work really hard in your own practice to not do it. It has to be a deliberate effort. And the people you ask for feedback are exactly the people that you're worried about not delivering good care to. Because they need to be the ones that are directing your QA, your quality and evaluation program. Because if you don't have, and that's not just for color, that's for gender identification and all of these things. This is a reality. And this is a huge part of all of this, because just like in the criminal justice system where we have this huge innate bias that has started and encircled for a very long time that's happened and ended up where we are now to create all of these rifts, it's no different in medicine. In fact, in many ways, medicine is a little bit worse because at least in law enforcement there is a conversation about it. However destructive or constructive it is, but at the same time right now in medicine, we have done a poor job of really having that conversation. And taking somebody's culture into account, because culture is block to block in many places. So we're getting a $1.5 million grant from the Robert Wood Johnson Foundation to actually create a national culture map. And what it's going to be, we've hired 3 anthropologists and 3 psychologists to build a questionnaire about culture, like how people can be defined by culture. And then we're going to go to every zip code in the country and interview 20 people. And we're going to ask them about their culture. So that if you have a question about what the culture is in a zip code, we will have found. Now, some zip codes don't have 20 people. Like if I'm going to go up to the UP, I'll be looking around for a long time. But that'll be super cool doing it too. I'll be like, oh my God, this is horrible. But I don't want that job. I'm totally giving that to an intern who I don't like. But but when we do this, that's going to start to get to the crux of the problem. Because if I'm going to go work in a neighborhood and we're rebuilding working with LA County to rebuild their addiction system. So that's 10 different states. It's 10 million, 11 million people in LA County, but there's 10 solidly different cultures in that one place. So it's like, it's bigger than the size of Michigan as far as population, but it has a much more diverse culture than that. And So you can walk 3 blocks and be in a completely different culture than you were. They may visually look kind of similar, but they're completely different culture. And as well as how they identify. So once we get to the point where you can say, well, I'm going to be working here and my patient lives here, and you can click on that culture map and you can pull up the 20 questions and the way that they answered it and listen to a clip of 2 or 3 people giving a verbal answer of how they identify, how they talk about their culture. That's going to be, I think, a better way for us to really understand, because I've been through, how many people in any of their onboarding at where they work go through the cultural sensitivity training stuff? That is horrible, right? It's so bad. And it would be better if you just said, I'm going to give you a day to walk through a neighborhood you've never been to. I mean, that would actually just be better. I mean, so I was in Iowa, I guess a month ago, downtown, and usually when I go to places that I haven't been, I just kind of wander around like in the place that nobody else likes to go. Everybody's always super friendly. You just go down, you throw on a t-shirt and hang out, and you're like, hey, I'm Dr. Waller. I've been asked to come here and talk about some stuff about building a better pain system or treatment system. What do you have to say about that? You will always get an earful. I mean, and it's amazing when you just ask the question. I'm not here to help you. I don't know what you need. I mean, that's not my job. My job's not to help you. It's just I'm going to hand you things that I may have that you can use to help yourself. I mean, that's it. You don't like this stuff, or maybe you do. Tell me. I don't know. And just if that's how you approach it, then you actually get really relevant information. And you can find that the country in many ways is really divisive in a couple of areas, and places, and they'll be straight up about it. But man, to hear it, in the raw form is really helpful in trying to devise systems of care. And so I would say for those of you here in Cass County, if you're helping to devise a system, you have to know which culture you're devising a system for, because the words you use, the angle you take, is family important or is family not important? Is the most important thing that they feel like they're still the person in charge, or does that have nothing to do with it? Is it a male-female thing? Is it a grandmother-mother thing? Or is it, you tell me what that is, because once you understand that, then you can really develop an amazing system of care, to be able to, to do these things. So this is huge if we can start to think about what we can do with culture in medicine, because it is not just what I rattled off about buprenorphine starting at 16 milligrams, go up to 24 if you need it, and down to 8 after a period of time, and then you maintain that. Because within that wrapped is geography, is culture, is the thought process, is this unconscious bias that we have. So I think most people, so when I walk into the room, I don't ever wear a white coat anymore anyway, but when I go into the room and I sit down, I'm just like, what's up? How's it going? I mean, that's it, because what they expect is me to walk in and be like, hi, I'm Dr. Waller. I'm going to be taking care of you today, and we're going to take a look at this stuff, and we're going to give you some medicine, because that's what we do. We're going to follow up, and we're going to do this. Any questions? Thank you. I mean, that's what they expect. But if you walk in and you just sit down and you're actually a person, like a human, where you can have a conversation, and you care, and you really do. It's not like fake care. Like, oh, I care so much about you. Reading your palm, reading your phone. That's really important to me. So those are important aspects to this, and they shouldn't be looked at as second. We'll look at that later. That has to be along with. So yes, you need a payment model so that we can deliver medication to people who need medication. Fine. But how do certain cultures look at medication? So if you take certain cultures who look at medication for mental health, we still have miles and miles and miles to go for those cultures, because they still don't see schizoaffective or schizophrenia as a neurobiological disease. It's like, he's crazy. That's it. It's not, and that's a crazy person. I don't want anything to do with it. Death and dying is a completely different modality for all of the other people, how they deal with loss. If you want to know how somebody's going to deal with getting off of a drug, look at how they would deal with the death of a family member as a culture, because it's the same attachment theory problem. So if they're a culture that has a complete catastrophic meltdown when a family member dies, that's how they're going to behave right around the time that you're taking away the one consistent thing that they had. If they're a culture that more introverts and doesn't say much, and they kind of like the one little tear down the side, kind of suck it up kind of culture, then that's actually the behavior you're probably going to see as you're pushing them through treatment. Neither of those is wrong. They're just very specifically related to that culture and how they have assimilated the way in which they communicate and connect with the rest of that. So it is very much about it. I don't know what you guys were hoping to get when you came here, but I have almost given up on giving doses and stuff like this. I mean, you have the guidelines. I think they printed out copies for you guys, did they? Fine. All of the doses are in the guidelines I wrote. They're all in there. And we're going to be updating those, and they'll be updated in the next few months, and it'll have the new meds and the new doses and the new pathways and all the new extensive reasons you can use this and that. And we're going to be doing alcohol as well. But the biggest things that you can't write in a piece of paper is really understanding that as a community, you have to treat this disease in that way. And if you don't, then it will fail. Then you will have a couple of clinics that do well and maybe see some patients and do that. But overall, it's not going to really move the needle.
So how do you deal with the issue of mental health and substance abuse? Substance abuse first and then mental health second is not a health system issue. It's a community health issue, and you need to find community health resources to deal with that when really it is a medical issue.
Right, so the question is dealing with mental health and addictive health and understanding it's more of a community health issue, and that's actually very true. And it's a medical problem, but it also is a community problem. And so let's talk about mental health. Big topic, right? It's the big umbrella of people that live outside of this curve. So we have society that has this curve. We have the people that live on this side of the curve that are like super depressed and introverted, and we even move down on, if you wanted to get into certain brain diseases, you can get into people who are on the spectrum down in this area, and that cognitive piece where they disconnect from society. And then you have the mental health diseases on this side that overconnect with society. Bipolar 1, hypomanic, or full manic, and then you have bipolar 2 with hypomania, and then you have the psychoses and the kind of the outward process. And then everybody in between, which is normal, kind of boring, but you can totally count on them not to freak out at any moment, to, wow, they're kind of fun, to, wow, they're eclectic, to, man, I cannot be in a room with that person, or I will go crazy, but not quite needing medication. And then we start to move out to there. I mean, that's just the normal society. So what we have to look at is what in society is the biggest issue with each of those. So introverted, extroverted require different medications because they actually have to hit different parts of the brain. And they may use some of the same axes, but they change the equalizer of the brain in different ways. Therapies actually are, if applied properly, are different as well. Because if you have someone with the negative symptoms of schizophrenia instead of the positive symptoms of schizophrenia, the positive symptoms of schizophrenia are going to be the auditory visual hallucinations. The negative are going to be the massive depression, introversion, and at its worst case, catatonia, right? So that's all the way over to that spectrum. Now, I've seen a person die of catatonia. 35-year-old dude died of catatonia in a VA hospital. Audie Murphy, when I was in medical school on my VA psych rotation. Crazy, right? I mean, I guess that's the wrong word to use in this topic. But but that's probably the better way to use that term than when addressing actually a person. But when we're looking at those things, that is a subgroup of the population that really requires the ACT model of treatment, the assertive community treatment model by Sarah Test, I think is who, a social worker, nurse. She was a nurse in a psychiatric unit that actually one of her colleagues, who was a social worker, went out to see all these patients. And I cannot remember the name of the social worker, but she would go out and she had great outcomes. Her patients never came back, and so she created the ACT model. And she did. Like this one person created what we see as just kind of a normal thing. So she created the assertive community treatment model that lived in this place for a while that worked really well and then expanded out and expanded out and expanded out. And that is the model that's basically taking the medicine to them. That's getting somebody out to them, and that's giving them the wraparound services. It's making sure that we understand what's going on within the community so that the community can then wrap them around, and maybe you can get churches to help, and maybe you can get other community organizations to help with this and make sure that transportation is set up, that they understand. On my block in South Jersey, I have 3 doors down on the left, a 55-year-old guy with schizophrenia, and he gets injectable medications. He's the son of the mom who lives in the house, He stands out front and smokes all day. And he has the positive symptoms, because I'll see him actually having some active hallucinations when I like drive by to pull into my driveway. I'll see him kind of, you notice, I mean, you know what it looks like when they're actively having it once you've seen this for a while. And then across the street, a son of another female who lives over there, she's actually a nurse, and her son, who's also like 48 or 50 years old, has schizophrenia, gets an injectable medication. I'm like, I don't know if we're drinking the water in Jersey, but as we're looking across, I mean, he has very much the negative symptoms. He'll come out front, if he even comes out, and he'll just kind of stand on the front porch and look down and not want to talk to anybody and look kind of scared and then walk kind of back in. And that's kind of his normal MO. You know what? They both need monitoring. And I guess the best way to describe it is what happened when I first moved to the neighborhood in my little feral 4-year-old. So we moved into a new house. We don't know the neighborhood at all. So Charlie, my little feral 4-year-old, I'm in the house and I'm on the phone trying to do something because we found like mold in the ceiling and there was a leak in the bathroom, and so the ceiling partially collapsed, and so it was like super awesome, yay Jersey. And then we moved there, and then so I'm on the phone with somebody to come out and do like mold abatement and this and that, and I'm like, where's my kid? It's like 3 seconds later, and he's like gone, nowhere to be seen. And I'm going upstairs and I go downstairs and I look out back, he's not there, and I walk out front, and what I see is my neighbor from here, my neighbor from here, and my neighbor from here converging on the other side of the car that I couldn't see. So the car's right here, and on the other side was my little naked 4-year-old child, and in the middle of the road, like trying to open the car door because he left a Lego in there. And that ultimately is how I imagine the approach that we have to really take, because these are people who are out there absolutely for the safety of my kid. I mean, these are people I hadn't met yet, and now they're like thinking, who is this guy moving in with the crazy naked 4-year-old kid? But this is kind of the approach that we have to take, is that we kind of are our brother's keeper in a way, and that if we take on this, it takes a village approach, then we're going to be able to do this. But the minute that we stop that, the minute that we turn away and we introvert, which is really where we live right now, we've pretty much done that for mental health and addiction. If we open back out to that, and you don't have to take everything on. You know, it's not like I'm gonna go across the street and be like, hey, did you know I'm an expert in these areas and I'm happy to help you. Call me at 2 o'clock in the morning if you have trouble with it. No. But if he looks like he's in danger, I'm gonna do something. You know, and I'm gonna stop, and I'm gonna get out of my car, and I'm gonna know how to talk to him, and I'm gonna know how to calm him down if we need to. I'm gonna make sure that, you know, that if the police have to be called, that they understand the situation as best we can, and hopefully not lay down and get shot. That would totally suck. But the reality is that as we look at what's happening, I think it really does have to be a village mentality. That we really just have to own it as a community and realize that 1/4 of the people that live in your community have some form of an addictive disorder, and whether it's a behavioral addiction, you know, with your, is it 3 casinos? No, I'm just saying. I mean, there are a lot of places. They're in Philly. They're in Atlantic City, a dying city of casinos there. But I mean, honestly, behavioral addictions are just like chemical addictions. It's the same dopamine rush. It's the same thing. You know, sexual addiction, gambling. These are all kind of in the spectrum of the same disease. And so if you take all of those people, 1/4 of the people out there. Now, there are a subset of the population in this room that have addiction. They have it. It's active. You know, they're working, they're showing up, and they hear what I say, and they're scared to death because they know that it matches the stuff that they're thinking about, or they're like happy because they realize that there's really good treatment, you know, for it, and they're eyeballing people around the room for who they would want to go and talk to after this to get help for when they do it, and that's fine. But the reality is, it is what it is. It is. The last memory I have of my grandfather is him being completely yellow on the front steps of a VA hospital. That's it. I didn't have any idea what that was. I was like 10. But that's the last memory I have of my grandfather. You know, he's a fighter. He was a bomber pilot in World War II in Korea. Cool guy. Last memory I have? Yellow. Sitting on the steps of the VA. We all have kind of those family memories, right? We have those people that we know. We have the friends that we had. I have the friends from college that we went out and drank, and we all got drunk together. I mean, I tried really hard in college to be an alcoholic, and I was just lucky I didn't have the genetics. But at the end of the day, what we found is that there were some of us that didn't make it. that disease really made it to where they didn't make it. And maybe we should have had that conversation, and maybe we should have known what we could do, and maybe we shouldn't have felt embarrassed about, confronting it when we saw that behavior in the wrong place. I mean, these are the issues that we have to actually start to work on.
So what advice would you have for family members or people that are close to you? Because, they'll suck the life out of you,
Yeah, no, they do. You have to flip the switch even faster than a provider on behavior as a symptom. You really have to do that, and you yourself have to get therapy. You have to find a therapist, and you have to go to it, and you have to sit there, and you have to say, help me figure out how to be not family. Because family is they're the first people to get crushed in this disease. Because we will, as family, do what family does, support. There's a word for that in behavioral therapy. It's called enable. And that enabling behavior is so enmeshing, and those interactions are so connected that we won't even see it. We won't even see it. It is, I'm saving you, and I'm trying to make you better, and I don't want you to die, and I'm scared to death, and I don't know what to do. And then at the end of that, you have to realize that there's free will. That they have the capability to make those decisions. The best you can do is lay the path out in front of them. And not give them your wallet, and lock up all your meds, and lock up all your stuff that you don't want stolen. I told my parents, so my middle brother had some issues in high school. It was a little weird because it doesn't match any of the stuff that I see, and I was at college, so I don't really know exactly what went down, but he went to an inpatient treatment, and he had like a DUI in high school, but he had been stealing from my parents and doing all this. Now he's totally fine now. He's like in his late 30s, married, kids, working hard, no issues, fine. But when I go back and look, that little episode really just destroyed my parents. It was, because I was a pretty easy kid. I ran track, I didn't really drink, and blah, blah, blah. I went on, and this and that. But man, he just broke that house. Because I went back for Christmas, kind of right after all of this stuff really started going down. And talk about like the negative symptoms of schizophrenia. It was, everybody was introverted, looking at the floor and quiet. And I'm like, hey, what's going on? I'm all, Johnny, this is cool. It's Christmas, good to be home. Go some laundry, and that kind of stuff. And everybody was just like sad, just like super sad. And so having to deal with that on a daily, regular, ongoing basis will break you. It just will, especially because you're so connected with these people. And so one of the first things is that you cannot get somebody better unless you yourself have the ability to disconnect from that problem, and especially with addiction and mental health. And so absolutely going to therapy, and whether that's like the Al-Anon type stuff, that can be helpful. If it doesn't work, then one-on-one therapy for acceptance commitment therapy is actually something that's been shown to be really helpful, and just really accepting the fact that this is what it is and where it is, and you're committed to feeling comfortable around that, and figuring out how to work through it. But you need to have, anyone who has that issue needs to be able to see someone who is an uninterested third party who will help them to know how they work through it. And all you can do is lay it out there and not enable. That's the big path. And that's actually true for school too. I've seen teachers get stuck on this, and social workers get stuck on this. Less doctors, because we're all pretty cold-hearted. But yes?
Doctor, what role should law enforcement play in the treatment of addiction in your view?
That's a great. So what they should do is they should capture and guide. So it's a capture and guide role. I don't want it to get outside of the role that they already really have. Currently, it is a capture and guide role. You identify the behavior that's illegal, you then capture the person based on that behavior happening, and then you guide them to the jail. I just want the guide piece to change the direction. That's really what it is. And so, but I also don't expect police officers to start making delineations between, is this addiction or criminality? That's where the drug courts come in. This is where, if they broke the law, the job of a law enforcement officer is exactly what their title is, law enforcement. The one piece that I think that I found that's been the most fulfilling for the law enforcement officers that I've worked with is having naloxone, Narcan. This is one of the most empowering things that I've seen. And I've seen, and I've worked with law enforcement at the federal level and local level and all of that, and the fear of having to someday take a life is one thing, but the capability to save one is pretty amazing. And you will realize that you will immediately, especially they start keeping tallies at the police departments that do this, and they have the lives saved tallies, and they have an annual conference, and whoever saved the most lives actually wins a prize. And I mean, it's cool. And it actually turns out to be a completely different way that the police can interact with their community. Because when you go out, you're there to protect and serve. And that really feels like that when you go up to somebody who's not breathing and they're about to be dead and then they're not. I mean, that's a pretty amazing thing. So law enforcement should do their job, should try to do it with the understanding that a lot of the behaviors that they're going to see are symptoms of a disease, almost all of them, to be honest. Because at the time in which you interact, anybody that I've had to go hands-on with in my role in law enforcement, I can't think of one instance where there wasn't a substance or a mental health issue going on at that point in time. So if you're going to go hands-on with somebody and it gets to that point, that means that you are now treating the most severe versions of the behaviors of these diseases. Rarely will people choose that path with a police officer. Sometimes they do. I mean, there are those, and those are really just called criminals. But when you go to prisons and jails and you look through the people that are there, in Indiana, actually, they did an evaluation where they found that greater than 90% of the people in their prisons had, their state penitentiaries, had an identifiable substance use disorder. That's not counting nicotine. If you counted nicotine, it's 100%. So when 9 out of 10 people there have a substance use disorder, you can bet that the vast majority of the reason that they're there is because of that substance use disorder. So, but what we don't need to do, I would like to blur the lines a little bit, but we still need to have a distinct reality of what an officer's job is. Because it's a dangerous job, and it's one that takes a lot of focus and a lot of practice, and now a whole lot more of introspection to understand how you interact with a community that maybe doesn't look like you, doesn't feel like you, doesn't sound like you, and to make sure that you're not doing that with unconscious bias or conscious bias and holding each other accountable. I mean, there's a lot of stuff on the plate right now, but the big thing is behavior is a symptom of something, no matter what the situation is. And if you understand that, even from a law enforcement thing, you can de-escalate a lot of situations without having to get to that point. And so it is identify, capture, and guide. I mean, that is it. But to guide them to the right place, and the more drug courts that we get and the more capabilities that we enhance to be able to identify the why that this happened, then we're going to be able to get people into treatment rather than guiding them down the pathway of, incarceration without treatment. So, question?
Just a question, on the clients that have had Narcan, is there any data on whether those clients have continued to use, or do they then seek out treatment? Is it beneficial?
So the short answer is harm reduction. We'll take that as a big lump thing. So harm reduction, needle exchanges, places like, let's say in Seattle, where they let you just go in and use heroin, in those places. Yes, there's an increased percentage of people that seek out treatment when there are places that they can go that are safe. They also decrease transmittable diseases and all of those things that happen, and overdose deaths and that. I have not seen data specific to the Narcan reversals and those entering treatment. I think that has more to do with us not offering treatment. Because what happens, you reverse a patient, where do they go? Emergency department, unless they refuse transport. If they refuse transport, what are they going to go do? They're going to go use. Refusal of transport equals I'm going to go use because I'm in florid, horrible withdrawal. Now, it also means they are not dead. So keep in mind that if you reverse someone and they're alive, that's somebody's kid that's not dead. And that is one more chance to get them into treatment. I mean, it is a death reversal serum. I mean, it's pretty amazing. But they might go use again. Yeah, okay, fine, they might go use again. But they're not dead. I mean, in any other disease that we had an anti-mortality serum for, we would be like crazy, right? Oh my God, he died of a heart attack. Oh, no, he didn't. I mean, that would be a quadrillion-dollar, drug. So I don't know why it's any different for how we treat this disease and the way in which we go about this. And again, it comes down to the stigma of this disease and the bias toward a lot of the individuals that they appear to look like by that time, by the time that you're that. But I've also heard, what about, my 17-year-old son who overdosed in the bathroom, and I didn't have anything to do for them. Yeah, that's a very real scenario that happens. And so who should have Narcan? I mean, I travel with Narcan. I mean, so as an ER doctor, I have a lot of, like, I can intubate you, and I could put like a balloon pump in you, and I can do a thoracotomy where I open up your chest and sew up your heart, but I can't do any of that without equipment, right? If I'm not sitting in a hospital. So the things that I can do outside of a hospital with bare minimum equipment is epi for anaphylaxis. I can give somebody Benadryl, an inhaler for somebody having an asthma exacerbation, and Narcan. Those are the things that and a little pocket knife if I ever want to crike somebody, which I did do at a McDonald's, and where was that? That was Florida. That was super fun. But you have to do, as an ER doc, you have to do it and just be like, what's up, can I get another fry? And then you just got to like leave. You'd be like, drop the mic and just walk out. I mean, that's, you can't stay around or anything. It was super fun. But But that's it. So I mean, why doesn't everybody in this room who understands addiction and knows that it occurs, why doesn't everybody here have Narcan in their pocket? Why in every school is there a rock star? I love that. So why is there not every place, like everywhere there's an AED? Because we put these energy devices on the wall that a random stranger can pull off, slap it onto another human being, and then shock the crap out of them. And we do that by design. We've allowed that to happen, right? We've done that because we know that without it, that a lot of people are going to die needlessly when we can change the rhythm of their heart. In every single one of those, there should also be one of the little voice-activated Narcan things that says, please push the top button. Okay. Step 1, don't inject yourself, which by the way happens all the time with EpiPens. So that's, if you've never done it or never seen it, it's like really hysterical. And when it's somebody else, if it's you, it's not as funny. But because their thumb turns like all white because the blood vessels constrict, and they're like, oh, and you just kind of make fun of them. But but as we look, I mean, these are really practical solutions, right? Somebody's not breathing, and who's the first person on the scene? A pedestrian or a cop, usually. Now in the rural area, it may be a little different, it's a little off, but in general, it's a pedestrian, generally a known pedestrian, somebody who knows the person, followed by police, followed by EMS, or actually followed by fire, depending on how your response time is, and then followed by EMS. So if we only give it to EMS, holy cow, we've missed this opportunity, that opportunity, this opportunity, and this opportunity. By the time they get here, he's blue, and we've knocked off the last few good neurons up there. So the goal is the earlier you can give it, the better. Saving a life absolutely increases the chances that they will show up somewhere for treatment down the road because they're alive to do so. Other questions? What we got? Yeah?
Working for family preservation, is there anything in place, like parents that test positive for THC or babies that are being born? What is in place so that we can eliminate the removals and try to preserve the family more, so that we work with, say, addicts in the home to work on keeping their children there? I know earlier in the day you talked about the trauma that it causes for both. I mean, it is trauma for child and parent,
Yep.
but also the addiction that comes with that. Now they're experiencing the trauma, and now we're back to addiction, getting that addiction fixed.
Yeah, so it's a good point. So the question is, what can you do about moms that are positive for drugs and the babies that are born to them, and how can you prevent some of this? Because when you remove the kid from mom, you actually cause trauma, for that, and you cause trauma for mom again, or you reignite early life trauma of that separation of what that is. The biggest thing that you can do is screen everybody with the idea of treatment, not the idea of getting them in trouble. So this requires an interpretation of the law that lets your legal people be okay with explaining. So I've heard this interpreted different ways from the state. And where you have to, so I've been told that if I test every mother and they test positive any time during their pregnancy, that I have to turn them in, that I have to report. That is, however, not how it's practiced, and nobody does that. And I don't know if I agree that that's exactly how that's, I would disagree with that interpretation. And the people who've given me that interpretation are not lawyers. They are just the people, that's how they've been told to look at it within the state. I've also heard the other interpretation that if mother is not positive or baby is not positive at the hospital, then you don't have, you have to test if you suspect. But what happens when you suspect and test? What does that equal? Racist medicine, without question. We've looked at those data as well, and in 4 different hospitals, we looked at that data, and what it showed is that if you just test those that you, quote, suspect, it is about 7 times African American as compared to white, despite them being a portion of the population that is a whole lot smaller. It's just racist. So you either test everybody or you just stop testing. So here's the thing. Baby has to test positive, right? Why are you testing baby? Yeah, but is there a mandate to actually test baby? No. There's not a mandate to test baby. So what does testing baby do? In the improper hands, causes a whole pathway of snowball crap to happen. In the right hands, it gets them help, and it gets them the right thing, and it gets them the family engagement support that they need, that the state can provide, and do all of these things. So what has to happen, I don't even know why we test. I mean, you can test baby from a medical standpoint, but I'll tell you, quite honestly, the vast majority of my pediatric colleagues don't know what to do with it. When I talk to them, how are you going to treat the neonatal abstinence syndrome of somebody with an SSRI or a benzodiazepine or things like that? They're like, well, it's just not taught. Just like it's not taught for what we are. Even the NICU docs have trouble identifying what is exactly causing an angry, frustrated baby. Maybe it's that you pulled them away from mom and you put them under a hot light and nobody's holding them. Maybe that's why he's pissed, right? Because when you swaddle them and give them to mom, all of a sudden that score that we look at called the Finnegan score gets a whole lot better. So the only way that this is going to actually work and not feel mean and punitive is if, one, CPS is trained appropriately and given a chance to understand. Because right now they don't even really have that chance. I mean, you have a lot of times a bachelor's level or a new master's level in social work, and there's not a lot of addiction training in that pathway. And then they need to then work with the treatment professionals. So what we did is when we would identify moms that were positive, they would then come to our clinic and we would try to engage CPS. You want to know something funny? CPS is not allowed to see the patients until after they've delivered. So I can't even get them involved in care before, even though that's what we wanted. I wanted them. So what we did is we made sure that our moms are prepped, that they understand, that we put a good note in there so that it said exactly what was there. But I'll tell you, I've had a rogue CPS, brand new first case social worker try to pull a baby from one of my moms that was totally stable in her own house doing exactly what she needed to do, and I went apeshit. I mean, I went nuts to the point of probably unprofessional. I mean, no, I was totally unprofessional, but but I could not fathom that actually happening. But in a court that is not equipped to handle this, they will take the word of the social worker over the word of an untrusted addiction doc. That is the one place on the earth that the social worker's word always trumps the doctor's word. For good and bad. So I think we have to just be careful with, we can get this information and we can make good decisions and we can create a good pathway, but it only happens if everybody's at the table and we're all on the same page. Because we can actually start to filter these patients for CPS so that we can get them the ones that really need them. Because you can't throw the whole thing out. You need to understand that with the team approach, that we are going to be able to do this. But without the team approach, it is chaos and it is trouble. So the things that you should understand. A community can absolutely fix this problem. It's a fixable problem. You have to screen. You have to identify, you have to understand where your gaps in treatment are, and you have to work together to do that. And the biggest piece is you have to just know what you suck at, right? This is the hardest part. And once you figure it out, then you can start to build up the better capacity to deal with those things. Because everybody always wants to talk about what they do well. But very few people want to get in a group and raise their hand and say, you know what I'm not good at? Whatever it is. I mean, that's what has to happen, because the minute you identify the gaps, you can fill those gaps, and you identify the barriers, and you can bring the people in to decrease those barriers. But as a community, you can absolutely tackle this problem. Each of you as individuals can make a difference for a few people, but that's it. And that's a reality. So you have to tackle this problem, but use data science and math to do it, and you will absolutely be able to get there. So thank you very much for the time. Appreciate it. Thanks. Appreciate it. Thank you.